Hello, everyone. Hello, everyone. Thank you for joining us today. My name is Savita Baja, and I'm the Vice President at the OKA for this year. Thank you so much for joining us. And we are going to be having an exciting presentation today on exercise and concussion recovery. So today's webinar will last about an hour. We have an hour to engage with Michael here today, and we will have the opportunity to ask questions. Any questions that you have throughout the presentations, you can ask through the Q&A box at the bottom of your screen, and you can ask those questions throughout the presentations. Clarifying questions will be answered throughout the presentation, and discussion type questions we'll save for the end and have some time for discussion. Today, we are honored to have Dr. Michael Hutchinson here with us today. He is the professor at University of Toronto and director for the Center of Sport-Related Concussion, Innovation and Knowledge. Dr. Hutchinson oversees an interdisciplinary clinical research team of professionals and researchers in the Faculty of Kinesiology and Physical Education, focusing on sport or physical activity-related concussions. He holds a PhD in rehabilitation science and is a registered kinesiologist. His present research focuses in areas of neuroscience, kinesiology, and rehabilitation. He also holds a scientist position at the Keenan Research Center for Biomedical Science of St. Michael's Hospital and the National Hockey League's Players Association. Without further ado, I'll hand it over to Dr. Hutchinson to have a great conversation today about concussion and exercise recovery.
Thank you, Savita. And thank you for everyone joining the session at your lunchtime or midday. Obviously, everyone has busy schedules and taking the time to kind of engage in this initiative and this discussion. I'm excited to share the information with you. This topic and area is very close to my heart in my day-to-day operations in terms of my role at the University of Toronto. So I'm excited to share this information with you and hopefully have some engaging discussions. I will say that given the weather, I decided to stay home in this context. So that's the benefit of a webinar, that we can do this online. Now, the downside is that I have a dog, and the dog does not seem like to listen to me at times. So expect some random barking throughout this presentation. Nonetheless, hopefully it won't be too disruptive. So let's get started. First and foremost, just kind of some disclosures here. Savita accurately articulated all the kind of affiliations that I have, but here are some of this is here for you. Again, I think it's important that I do acknowledge my obviously academic affiliations, as well as it's also important to acknowledge funding, like where the money comes from with respect to research. And thankfully, the Canadian government has been very good to our research program, and we've been well funded, both from the Ontario and federal side. The last one I do want to acknowledge as well as a commercial interest. I'm involved in a startup company, a mobile health technology that had kind of generated out of our research at the University of Toronto. This will come up later in the presentation, so full disclosure about that commercial interest. So yeah, that's just kind of being fully transparent, and I'll acknowledge that throughout. What are my objectives here over the next kind of 45 minutes, so to speak? I have three key objectives. I would like to go over some concussion basics. I realize that we're going to have varying levels of interest and expertise across the whole spectrum of health conditions, and we're dealing with concussion here. And I do want to provide us some foundational information with respect to diagnosis, pathophysiology, symptomology, and recovery. I don't want to spend too much time there, but to talk about concussion recovery and the role of exercise, we do have to get some of those foundational pieces in place. The second thing I want to talk about is what are just generally accepted management principles. And so I will kind of go through those. And then really the meat and the potatoes of this conversation here today and for our audience is really about the role of exercise in concussion recovery. This is a very exciting and evolving landscape. And I think it's really important, I'll kind of give you the punchline now, is 10, 15 years ago, concussion management was all about, oh, you have a headache, or you have issues thinking, just rest, get off your TV, get off your screens, don't be active, just, So roll up in the bed and hopefully you'll get better over time. Now, there was logic to that at some level, but I think in hindsight, that was a kind of misguided information, because what happens in the concussion recovery is if people don't get ready, well in a few days, well, then they're not engaged for long periods of time. And then you have kind of obviously complicating issues about isolation, deconditioning, all these things. So really rest is out the window now. We have a temporary period of rest, but that principle is now gone. And we're all about movement in the right way at the right time. And that leads to the second one, is that the first generation of our understanding of exercise was the progression of moving to a treadmill. We've also seen a progression to stationary bikes. And then now we actually moving into free space and with kind of sound movement principles. And I'm going to talk about this evolution here today. And really at the end here about sound movement principles, that's where the field of kinesiology really has its role here, because being experts in movement principles really can help a lot of concussion cases. And hopefully I'll get that across today. So let's start with the basics about what concussion is. And I first want to kind of start with the diagnosis of concussion. How does a physician determine whether or not you've actually sustained a concussion? And it is a clinical diagnosis. So when we talk about clinical diagnosis, that means there's no hard and fast brain imaging test. There's no blood test that they can do. Clinical diagnosis means essentially requires expertise and knowledge on a condition. And there's kind of an element of not subjectivity, but it comes up to their experiences and expertise in kind of parameters around arriving at the diagnosis. And concussion diagnosis requires two things. One, there has to be an event, and that is the biomechanical forces of head acceleration or that disruption of the brain. Plus, we need people to either behaviorally change, where we see someone behaviorally change, which is a sign, or they must feel unwell. And those two things together in close proximity are the definition of how to arrive at a clinical diagnosis. You just can't have an event and you can't just get hit and say that's a concussion. If they feel completely fine, there's no observable issues, their behavior is fine. And you can't just have, I feel like I have a headache. And you can't just arrive at a concussion if you just have symptoms, because many different reasons for symptoms can arise. So there has to be that corresponding event that goes with it. Okay, so let's kind of break this down just a bit. Well, what is the event? Well, really what we're talking about here is the disruption of neural tissue in the brain. And on the left-hand side here, we have a really fancy image showing some diffusion tensor imaging. All these different fibers or these kind of networks show different tracts of brain tissue. And here, obviously, this is someone's nose, mouth, and forward looking this way. And what you can see is that we have a very rigid structure, obviously being our skull, and then we have fluid in here, but then we have brain tissue in here. And different regions of the brain have different densities, as well as cerebrospinal fluid and encasement all around the brain as well. Now, realistically, under normal conditions, the way we are constructed is very good at handling transient deformation. So you can obviously shake your head and it's no issues. You can jump up and down. You can jump off a box, and there's no issues with moving your head quickly. You can run and stop quickly, and it can handle those. The problem is when the acceleration or deceleration happens very quickly. And given, the biomechanical kind of issues with the fact that different tissues are going to move at different rates, then you're going to potentially have different stresses or strains. And what I provide here are kind of the three basic ones: compression, and that can occur maybe against the skull; tensile, that sometimes occurs kind of more in the midbrain; and then shearing is obviously movements in opposite directions. And given that you have neural tissue that's kind of moving all around in different directions, well, you're going to have potential shearing as well. So that hopefully gives a little bit of an idea of what the biomechanics. And we think of typical events of when a concussion happens. Someone slips and falls and hits their head on, like today, on an icy condition, hits their head on the environment. Or we see in sports, maybe hockey, someone is hit with a shoulder to the head, or they're in football, obviously helmet to helmet collision, when they're both running and they collide and it's a very rapid come to a stop. Those will be common situations. Now, on the flip side, what are signs and symptoms? Signs would be obviously something that the practitioner or someone can see. Vomiting, someone throwing up, that would be a sign. Someone who's a loss of consciousness or motionless would be a sign. Someone who's difficulty balancing, visually you can see someone having trouble, that's another sign. Then you also have symptoms. Symptoms are subjective, which comes from the individual. And we have maybe, 4 main clusters. We call them physical or somatic. That's something like a headache. Cognitive would be stuff about word finding, thinking, memory issues. Emotional is a big one in concussion. Irritability, sadness, feeling down, anger. Those are all emotional components. And then sleep would be another one. This is the one that in concussion seems to go in 2 ways. Sometimes people with concussion, all they want to do is sleep. They're really fatigued and they sleep quite often. And that's a potential issue. On the flip side, others, the same diagnosis of concussion, and people can't sleep. And it's the one symptom that really goes in either direction. Everything else goes in the negative direction. Like you don't get happier, you don't get smarter or anything like that. So all these other ones go in the negative direction. And so that's what we're left with. In totality, we need to have the event of the rapid acceleration of the head, plus some functional brain injury, which is manifested by how a clinician or someone can see something or evaluate them, plus presence of how they feel. So that lays the land for the diagnosis of concussion. Maybe just pause here for a quick second if there's any questions with respect to the diagnosis. I'll give that a second, and if not, I will then keep going. And the one other kind of piece about symptoms is people often ask the question, well, when does the onset of symptoms happen? Let's say this morning, I went out to shovel the snow and I fell and I hit my head. Well, when would I expect to feel unwell? What happens if I got symptoms a week from now? And I woke up, 7 days from now, I'm like, oh my gosh, I have a headache. Can that be concussion symptoms from today, 7 days apart? The likeliness of that is very low. What can happen is I could hit my head this morning, and then maybe I don't feel well after this conversation today because I'm kind of stressing my brain. I'm thinking a lot and trying to kind of make sense of obviously a certain topic. And maybe later on today, I get symptoms. That would be reasonable. Maybe even tomorrow morning, if I woke up and had symptoms, that could happen. So it's not always right away. As soon as you hit your head, you automatically need to have symptoms. We typically allow for about 24 hours for those to potentially come up. But if it's a week down the road, that's a little bit too long for us to accept. So hopefully that makes sense. Let's keep moving on. We're going to move on to the pathophysiology. So quickly on this one, I provide a reference if you want to continue with reading with this, but this really comes up out of the work of Gies and Hovda out of UCLA. And really, one of the hallmark things about concussion is that really there's no macroscopic neural damage. What I mean by that is if someone has a concussion and they go to the emergency room and they say, okay, we need to do a CT scan, we need to do an MRI. The only reason they're doing that is for the purposes of ruling out more serious brain injuries. If there's a potential hemorrhage, bleeding in the brain, that's what they're looking from a standard kind of ER imaging approach. You cannot confirm a concussion through that process because it's completely normal. So what we're left with is you have the event of the biomechanical injury, and what happens at a very kind of smaller level, more granular level that we can see in kind of current day technology that's an emergency room is that there's issues with membrane permeability. And what we're saying about that is that the walls or the structures of our cells are no longer intact the way they should be. And so things get in and out the way when they really shouldn't. And so you end up with a flux of ions, sodium and potassium, that's the real big one for concussion, as well as energy utilization and glutamate. Glutamate is an excitatory neurotransmitter, so that can also occur with the biomechanical injury. And in the end, what happens is you have alterations in energy utilization and blood flow. So concussion's not, tissue leaking out your ears or your nose, or there's no bleeding inside, but really it's a disruption of the system and function in terms of blood flow, neurotransmitters, and ions. And again, you can kind of go through the reading at your own interest, but just to give you an understanding of what exactly is happening, on the y-axis here, we have starting from 100% here. That means compared to normal or your normal base. And then below, obviously, is going to be less. And then above is going to be more. And then on the x-axis, we have time, so being in days. And what you can see is a lot of stuff happens very quickly in less than a day. And so the first thing I'll point out is that there's a potassium efflux. And again, when we think of neuronal cells, the sodium potassium pump, really the whole purpose is obviously to kind of have a negative 70 charge. And that is kind of happens through the sodium and potassium pump. And what happens when there's membrane permeability, the potassium gets out, so-called all the cattle get out of the farm, whatever the analogy is, and you need to bring them back in. There's a question here I'll get to in a second, so just let me pause there in a sec. And then what we have also having is obviously glutamate going, excitatory neurotransmitter, and that essentially creates a situation is that your body says, okay, something has happened, let's restore homeostasis. Let's get back to that situation. And we need to use our internal existing energy stores, glycolysis, whatever that may be, to really kind of get our cattle back in the farm, so to speak. Now, the one thing that's kind of seems counterintuitive is you would think if you're in need of trying to have energy because you need to get everything back to homeostasis, well, a sensible thing is that, oxygen or blood flow should provide us that means to help us. But what actually happens in concussion is we have a decrease in blood flow. And that we don't exactly know why that's the case. It could be protectionary. It could be, obviously if you have a more severe brain injury, like a stroke or a hemorrhage, then yes, you don't want more blood going there. So it's not exactly clear what is going on with respect to that. But nonetheless, it appears there's almost like a mismatch. We're in need to restore homeostasis, but we're presented with an environment of less blood flow. And so we quickly kind of use up our energy stores, and then we end up in oxidative dysfunction as well as hyperglycolysis in the presence of a decrease in cerebral blood flow. And this potentially lasts up to 7 to 10 days. And what I've described for you has really been validated in animal models. However, we are seeing very similar things in humans. However, the timelines are slightly different. So a couple of questions here I can see in the chat. Okay, so good question here. If a hockey player hits their head on their boards or loses consciousness, do they automatically assume they have a concussion? That's a good question. There's a couple signs that almost automatically can arrive at the diagnosis of concussion. One would be loss of consciousness, would be one sign for sure. And the other one is motor impairment or discoordination that cannot be ruled for, that is brain-related reasons. Obviously, you can hurt your knee and have motor incoordination. But the reality is if you have ataxia or kind of motor incoordination due to a brain injury, that's automatic for concussion, as well as loss of consciousness would be automatic for concussion. Both of those things would happen. And then the second one, sorry, not sure if I missed this. Once you have a condition, are you more likely to get risk? So the second question there, I'm just going to table that one for later on. And I think it's a kind of a bigger picture one about the risk in the future. So let me bank that one for a second. So, okay, moving kind of to the point that, let's say we get through the whole process of the diagnosis of concussion has been made. Well, what exactly do you do? You've now just said, well, they're in this state of, metabolic dysfunction and, hyperglycolysis in light of, less blood flow. What do we do? Well, what we do for the first 24 to 48 hours, we have people chill out. That's really what we suggest in what we call the acute phase. In the acute phase is 24, 48 hours. So rest is not completely gone, it's just prolonged rest is gone. And hopefully it makes sense that we would recommend rest acutely because what I've just said with respect to potentially ionic flux, the blood flow issues, the glycolysis issues, if you continue to do more, if you continue to go to work, if you continue to exercise, then you're already in a state where your energy utilization is off. And we believe that can actually worsen things because you're kind of adding, you're pressing the gas on an empty tank. And we know you shouldn't do that to a car engine. And we don't want to do that to a human as well. The other thing is, if you're impaired, if you're just not coordinated, if you don't feel well, you're putting yourself at risk of injury. You're putting at risk of maybe more severe brain injury, that's for sure. But you're also potentially putting yourself at risk of, shoulder injury, ankle injury, whatever that may be. I'm just going to take a peek at the next question. Good question. I'm going to save that one as well for concussion tools. Actually, no, maybe I can answer that one now. So what concussion tools, would be helpful to arrive at the diagnosis of concussion? The SCAT-5, which is the Sport Concussion Assessment Tool, the most recent version is the SCAT-5, is the consensus guideline, consensus kind of acceptance of how someone should arrive at a diagnosis of concussion. Again, that is a framework for evaluation, not a diagnostic tool. So I think it's important that I separate those two. You require a physician or a nurse practitioner in Ontario to arrive at the clinical diagnosis, and the SCAT-5 provides the framework to make sure you address all the issues of symptoms, balance, cognition, neck, but nonetheless, it doesn't tell you on a piece of paper whether or not they have a concussion. It still requires that clinical expertise, but that would be the accepted tool for an evaluation. There's, the ones that are coming out that I suspect that we'll find out in the spring. Vestibular ocular VOMS is another test that's going to likely be useful, which is more ocular movements, is a potential another one that clinicians are starting to use more, and as well as tandem gait. Now, going back to this one, once the rest period subsides, or even not even during these, education also should occur at the same time, when they're resting. I would say education is probably the most undervalued component of concussion management. People sometimes almost ignore it, don't think it has much weight, but it has very good evidence that it is very useful for people. And particularly, why is that the case? Why would education be important? Well, the reality is someone's had a brain injury. There are varied responses in how they would feel, and normalizing the injury, giving them some basics of what's happening, letting them know that you're obviously not bleeding inside, as well as what symptoms to expect. It really helps kind of calm the person down, normalize them, as well as provide them sound principles moving forward. And the last one is reintegration. Concussion management is all about moving from not moving in that first 24 to 48 hours to movement in increasing in a progressive manner of more intensity, longer duration. And that is physical as well, but that's also socially, sensory, screens, TVs, as well as work, cognitive, school. you can apply that same progressive nature. I pick up the speed a bit here. This one here, I'm highlighting the fact, oh, my internet is unstable. I don't like that. Highlighting the fact that concussion recovery is somewhat variable in responses. What I mean by that is the time to recovery can be a week for one person, or it could be 3 months for another. And this is actually real data coming out of some of our work. So on the y-axis is frequency, and on the x-axis is days. And these are just it's a histogram of frequency distribution. And what you can see for some professional data that we have, most people return to play about 7 to 10 days post concussion. Now, what's interesting is when I show our university population, you can see that this is a skewed distribution. So the peak is here and then it kind of tails off, but we still have some people that are 3+ months. And in our university population, same shape of the distribution, but it's called what we say phase delay. So it's a little bit longer out. University population, about 3 weeks post-injury. And then our high school population is closer to a month and a very similar kind of phase delayed a little bit longer. There are many reasons why we could kind of potentially hypothesize, argue, discuss why these differences occur. And there's likely multifaceted. And multiple researchers have consistently noted that professional, university, high school, there is a longer time to recover. Access to care, is it potential biological? Is it just, multiple stressors? Some people are paid $1 million to do things, others are not. The reasons are varied. But nonetheless, important to realize that there are differences based on age. That helps also expectations for patients of when they potentially would get better. Now, it's not just about age as well. There are many things that contribute to potential concussion recovery. And I think of concussion recovery as like rings. And I'll explain what I mean by this is at the center of a concussion, there's that neurometabolic cascade that I talked about, the Giesenhoff model, that they'll have signs or symptoms. They may feel tired, they may have balance issues. And then there's the second ring. And the second ring is what also it happens at the same time as concussion. Can you have comorbid issues? And if you think about what happens in concussion, is your head moves quickly and your neck is connected obviously to your head. So a lot of times what we see is comorbid neck issues. Neck issues can cause obviously balance troubles. They can cause neck pain. They can cause sleep issues. Varied reasons or varied symptomologies that can happen. There's also premorbid ring. Premorbid is what does the individual bring into this concussion before? And premorbid can be also really important in how you potentially manage someone. And so I'll give you 2 examples. Example 1, the person feels tired, fatigued. They have no issues with their neck, no comorbid issues, but they have a history of one concussion. And so visually, that's what this concussion looks like. Now, the same diagnosis of concussion, but example number 2, this person has trouble thinking, they have balance issues, they're also tired, but they also have comorbid issues. They have neck pains, maybe issues with range of motion, and they also have 3 prior concussions, as well as a history of anxiety. Now, I've said that they both have been diagnosed with concussion. I would ask everyone to think kind of, practically, do we think that these people are going to be managed? Should they be managed the same way? And, sometimes in some cases they are, but they probably shouldn't be managed the same way. And we would have different expectations of what may be contributing to their symptomology and recovery time. I'm just going to peek at the chat here for a second. Do the lengths of time of recovery increase with multiple concussions? Not always. Good question. So just going back to the earlier one about recovery timeline, do we always see that with each subsequent concussion that they're going to get longer each time? And the answer is no. However, it would be a flag for us clinically about making decisions whether they continue with sport if they've had 3 or 4 or 5 concussions, and each subsequent concussion does get longer and longer recovery time, that sometimes is a flag to say, wait a second, maybe we should reconsider the sport that you're participating in. But it's not a given. Now, management of concussion depends on what phase that you're in. There are 3 key phases that I want to talk about. There's acute, that first 24 to 48 hours. And really, that's all about just education and just toning down the stresses. So chilling out for a couple of days, not doing too much physical activity. We don't say throw your phones away or don't watch TV, but bring down them, take frequent breaks. I'll hop to persistent symptoms. Persistent symptoms in most populations is usually after about a month. I'll just kind of broadly say a month at this point. And so that means they continue to have symptoms after 30 days. And then subacute is pretty much everything in between that. Is 72 hours to up to 1 month. So let's start with what's the role of structured exercise in persistent symptoms? So I'm going to start here in this phase. And I'm going to credit the work that was originally kind of constructed or developed out of the University of Buffalo by Dr. Barry Willer and John Leddy. And this is referred to as the Buffalo Concussion Treadmill Test. And so a few years ago now, they came up with the thought processes like, well, these people are symptomatic for over a month now. Why can't we, get them going, exercising? So that's exactly what they hypothesized. What's the problem after a month with getting people to exercise? And so they developed this treadmill test where for people with persistent symptoms, they would have them start walking on a treadmill at 3.5 miles per hour, and it was 0% grade. And what they did is they checked 3 things: their symptoms, their heart rate, and their perceived exertion. Those are 3 key metrics. And then what they did is after a minute, they keep the same speed, but they increase the gradient by 1%. And they say, any change in symptoms, they're monitoring the heart rate, how hard is this for you? And then they keep doing this after another minute. And they continually to do this for up to 15 minutes. And no, everyone, particularly on this webinar, most treadmills go to about 15% grade. And so you take them up to that top, and then the thing doesn't even go any higher. But now you can increase speed. And so, 0.2 to 0.4 each miles. So you've gone up for 15 minutes, and now at 15 minutes, you're going to increase speed. You're again, after each minute, monitoring symptoms, heart rate, and perceived exertion. If they happen to get more than 3 symptoms, a change in more than 3 symptoms in this testing protocol, it stops. It's saying, okay, that's called symptom exacerbation. We're stopping the test. And what they actually proposed, sorry, I apologize, this is a busy slide. They proposed 3 predominant types of concussions, one being physiological, second one being vestibulo-ocular, and the third one being neck, cervicogenic. And what you can see is, based on their treadmill results in this last row, how they perform on that test provides some information of the potential concussion that they're having. And so if people can't complete the test, if they can't get all the way up in the gradient, then that's likely maybe more physiological concussion. Now, if they're able to get all the way up and perform maybe even the entire way, you start to look at the type of symptoms that they have and what difficulty they have. So if I start on the left-hand side, if people's symptoms get worse with physical exertion or cognitive exertion and they can't do the treadmill, then that's likely a physiological concussion. If they seem to be able to do the test, but they have eye strain, then that's maybe a vestibular ocular one if they have dizziness as well. And then the neck one is going to be kind of positive elements around on the neck. Now, what was interesting, I'll probably highlight each of these. Yeah. What's interesting about this is that it didn't matter what bin they put them in. They had the same approach for treatment with respect to exercise. And what they suggested is, regardless of whether they're physiological, vestibulo-ocular, or cervicogenic, what they did is they took the heart rate at what time they failed, and they took 80% of that. I'm not going to try to do the math on this to give you a great example on the spot, but they took 80% of their heart rate achieved at failure, and that would then be their working exercise rate, for which they then need to do 5 or 6 times a week for at least 20 minutes. So then they were prescribed an exercise protocol based on their failure heart rate. I'm just going to peek on the questions. Yeah, good question. If I recall, they have validated this both in athletic and non-athletic populations. But you're right, there's going to be definitely some tolerance on obviously the speed and obviously the incline for potentially some corner cases populations. And so what they did is they, regardless of the type of concussion that they had the same exercise plan for people, and they would come back in a couple of weeks and do the same test. They found very good results for this protocol, and that was for people with persistent symptoms. So then the field asked, well, can that also be achieved here? Like, why do we have to wait 30 days? And so then we started to ask that question, and the Letty and Willer group then answered the question more recently in, I think it's a JAMA, is the very highly regarded paper. They showed even after the first week of concussion, you could get people to do a treadmill test, find their heart rate, and prescribe an exercise protocol. And that seemed to be better than usual care or someone not engaged in that. So we have seen the benefit of using a treadmill test to then prescribe exercise. We had a question at the University of Toronto a few years ago. It was like, do we need a treadmill test? Why not just apply sound exercise prescription principles? And we decided that instead of doing it on a treadmill test, why don't we get them on a stationary bike? Because bikes are usually more kind of prevalent, and they're easier for some people to use, and we're going to limit head acceleration. So we actually did that question. We actually asked that question, and we recently published this in this year, just in December of 2022. And we showed that having someone engage based on their heart rate max. So on the left-hand side here in this figure, we would start them off at 60% of their age predicted maximal heart rate. Very crude, very easy to do. Obviously, not hard to complicate, 220 minus age, and then take 60% of that. And we applied a progressive 15 minutes, 60%. Then we went to 20 minutes, and then we just keep 20 minutes, but we would do 2 on, 1 off, 2 on, all the way to 75%. So the goal here was, instead of having someone to do a test, can't we just broadly calculate what their ranges should be and get them going? That has benefit in the real world, because then you don't have to do a test, and then you don't have to kind of use another additional resources. Better maybe for rural communities, better for maybe non-concussion experts. And we showed, our results were very promising. Quickly, I'm just realizing that time is flying. To highlight here is that our protocol based on age predicted maximal heart rate was safe and effective at reducing symptoms. And we could do this after the first week of injury. So this graph here shows that the people who were in the exercise protocol recovered faster than those in the usual care. Very promising finding, early days on this, but really, really promising. So we've kind of gone from, do you have to do a treadmill test? And we have recently said, no, just get them going based on their age predicted maximal heart rate after the first week. So nonetheless, still structured, still based on certain exercise percentages. So this last thing I want to kind of chat here in the last few minutes here is, we then said, wait a second, we've gone from a treadmill, we've gone from stationary bike and just using maximal heart rates. What about not using any equipment and just telling people to do exercises that are just informed by basic physical literacy, kind of common principles, limiting head acceleration, and just coming up with a sequence, like a circuit training of exercises that may kind of help people. So now we don't even maybe need a stationary bike. We just get people to squat certain ways, lunge in certain ways, arm raises, and have our work to rest ratio in a very prescriptive way. And so we started this kind of work here on a mobile device using an Apple device. This is where I do want to acknowledge that it's kind of morphed into the startup company of Rhea. But nonetheless, I wanted to kind of spend time talking about the initial research or the rationale for doing this. We were asking the question, can we, with the ubiquitous nature of mobile phones and devices, and obviously not having someone to come in for a test or to train them, can we just give them a video and tell them, turn on your phone and start following these exercises? One question we were asking, can we achieve these heart rate ranges by going through a very prescriptive exercise protocol using our own body weight or limited resistant weights? And then could we progress them? Could we get them to go from one day to another day to a next day? And can we make them feel better? And we started this with people with persistent symptoms because they were just easier to find during COVID, to be quite honest. And this finding here shows you, these are the x-axis is users. So these are just unique IDs. The y-axis is their percent of heart rate ranges. And our goal to get them to start exercising was around 60% of their maximal heart rate, with 5% on each side of the bounds. And we were monitoring this remotely through an Apple Watch. And I will acknowledge that this research is under review at a journal right now. So it's not quite public, but it's on the road to being public knowledge. So I am sharing this information while it's under review, which I don't think is a problem as long as I acknowledge that. And what we can see here is half the people, these are box plots here. So this is the median value followed by the range. And so what you can see is that half the people got where we wanted and then half didn't. And so that's the data. It says, well, some people are bang on, like this individual, perfect, right in the middle. Some people maybe worked a little bit too hard, and some people didn't work as hard as they needed to. But nonetheless, half those arrived at that. What we did find is people did not feel worse after they did that, though. So better, same, or worse. Worse is what would be considered. So on the first session, after the second session, after the third session, what you don't want to do is make people feel worse with rehab. Now, in rehab, feeling the same is sometimes a win, and feeling better is obviously great. And so what we found with this research is say, well, we can safely move people because they don't feel worse after a few sessions, which is a win. This one was a bit surprising, I'll be honest. I did not expect to see this. What we showed is that if you use a mobile device for 2 weeks and you just follow exercises based on what the app shows you, how do you feel after 3 sessions, after 6 sessions? And that corresponds to a 2-week period. Symptom severity is on the y-axis, and then time period is on the x-axis. And what we found is after 1 week, there was a 33% decrease, and after 2 weeks from baseline, there was a 43% decrease. So that was very encouraging because, again, we're moving from this idea that, well, we can test someone that's an expert on a treadmill, prescribe exercise heart rate based on their achieved heart rate. That's great, but there's limitations to that. Requires people, you got to go in for an evaluation, you need a treadmill. The second one is, well, let's not worry about the treadmill, let's just get them on a bike, and then let's not worry how they feel, let's take their heart rate max. And then there was some wins there. And then we said, well, do we even need that? Why don't we just show people exercise videos and tell them to move in a proper way? And we've seen promise there as well. So what we're seeing is really the evolution of exercise in concussion management. We've moved from this period of don't do anything, you're going to hurt your brain and wait till you feel better. That's now gone. And we are seeing this movement saying, well, we need to be very controlled and clear on what they need to do, all the way to where I'm actually not even convinced we need to be that kind of rigorous on how we approach movement. We just need to apply sound kinesiology principles, making sure that they conceptually make sense, that they're scalable to multiple populations, and that we limit head accelerations, and we have general kind of bounds for what our target heart rates would be. So then the question is, if exercise is useful, well, how? Like, what's exactly happening? And we're not quite sure yet. I'll be honest. We know across multiple conditions, as again for everyone that's on this kind of webinar, that the benefits for exercise are ubiquitous across every condition. The mechanisms are probably similar across most, but not always the same. But one would, with respect to a brain injury, was it increased BDNF, or brain-derived neurotrophic factor, as one proposed mechanism that we know it's involved in neuroplasticity, protection, growth, and differentiation. We know that aerobic exercise stimulates that, and so that could be one mechanism. It could be also the regulation of the autonomic nervous system. We know that concussion involves a disconnect, an uncoupling between the central autonomic nervous system and arteriobaroreceptors in the heart, because obviously it's connected with the brain there, and maybe it's helping resolve the kind of sympathetic parasympathetic uncoupling. And obviously we know that exercise helps to stabilize or regulate cardiac function. Neuroendocrine, very similar function here, is that can cause sympathetic stress. Hormesis, obviously, if we stress and adapt, there's benefits around that. Neuroendocrine could be also a piece. And then there's this last one here that I have as well, is we don't always need to have a biological mechanism. And I think the most recent one of using the mobile app, where it showed that not everyone got to the heart rate that was required, but they all got better. So maybe it's not all biological. And one of the things that we found in some of the exit kind of questionnaires and interviews is a lot of people said, I finally had permission to do something. And people have kind of been under this umbrella of like, don't do anything, careful what you do, you're going to hurt yourself, to saying, listen, like I can move, I can squat, I can do all these things, and I'm allowed to. The concussion expert, this kind of platform said I can move, and maybe it's just a feeling of accomplishment, behavior change that has a wealth of information with respect to that field. And it obviously could be multiple factors, and like most things, it could be multiple. So I'm at 10 minutes in to go here, and I think I'm just about done. And so just highlighting that we have seen an evolution of a very exciting evolution. And I think the more as we get closer to the end here, the role of kinesiologists and how to move and how to move properly based on their limitations or abilities, I shouldn't say limitations, their abilities and potential restrictions. If we just apply sound movement principles, I think the field can contribute significantly to concussion management in creating structured exercise for people. Now, the caveat here is that simply just getting people to move from all concussions is not going to heal everyone. I think it's, in some cases, people are going to actually have like cranial nerve injuries. People are going to have headache disorders. They're going to have like potentially post-traumatic headache. They're going to have migraines, sleep-wake issues, vision, mood disorders. These are all clinical conditions that require certain medical expertise and different intervention opportunities. However, I will still say that exercise still has a foundational baseline component in any medical intervention, and it's just kind of finding that right frequency, intensity, and movement type. So hopefully I've achieved my objectives here of kind of giving everyone the concussion basics with respect to the diagnosis, pathophysiology, and symptomology and recovery. I've hopefully highlighted some elements of the management principles and the exciting role of exercises in concussion management. So that brings it to an end on my end, and I'll obviously welcome questions and discussions at this point.
All right, thank you, Dr. Hutchinson. for that insightful presentation. We have a couple of questions here in the chat. So we'll start with the first one here. Once you have a concussion, are you more likely or at risk for more?
Yeah, so that one I is a complicated one. So the quick answer is there appears to be a pretty consistent statistical relationship between those two things, that if you've had one, that you're more likely to have another. Now, it could be for various reasons. You could already actually have a pre-existing issue or risk factor pre your first concussion, and we're just kind of subsequently seeing this. The other thing is that once you have your first concussion, there may be this increase in knowledge, just you know what to do, you know for the signs and symptoms to look for, and you're more likely to report it. So it's not necessarily like you have a biological vulnerability for certain, but there may be some statistical relationship between people who had prior concussions are more likely to report one in the future.
Yeah. Okay, another question we have is, if symptoms stay the same during the treadmill test, but worsen within 24 hours from the test, could it be determined what type of concussion it is?
Yeah, it's not going to potentially, differentiate the time. So the time from the test to the presentation of the symptoms is not going to really clarify what type of concussion you have, only in the fact that there's still ongoing issues, I guess, so to speak. Now, what we usually do is try to figure out, is there potentially any other events in that time sequence that can contribute to it? If it's headaches, sleep issues, difficulty sleeping, the way you sleep, those things may contribute to the symptomology. So it's not just when the symptoms arise, but it's the type of symptoms that are people have kind of help to figure out what type of concussion may be contributing.
Yeah, great point. Another question we have is, for return to play, are we still focusing on 2 weeks recovery for 18 years? And if no symptoms, can they return?
So typically, are we still following 2 weeks recovery? I assume what the question there is that, if simply time elapses, if 2 weeks goes by, can someone just simply return? Our kind of protocols don't really suggest a time period requirement. It's about the progression of stages and completion of exertion and tolerance to school, tolerance to physical activity, and tolerance to just social issues. We say that a minimum would be at least a week, because you kind of need time in between each stage to see. So the concussion stages are typically, there's 6 levels. I didn't have time to go into every single level, but the progression is about 6 stages, and you typically want 24 hours in between each stage. So because of what the previous question was, what happens if you get symptoms later on? You need to see if symptoms arise after a period of time. And so really, to get through those 6 stages is at least 1 week, but 2 weeks is not an accepted landmark for recovery time.
Okay, awesome. Moving on to the next question. What is a good way to motivate clients or patients who are recovering from a concussion and are apprehensive to return to physical activity?
Yeah, that's a very good question. What we see is in concussion, and I'll kind of dichotomize 2 different conditions. In concussion, we seem to see people worried about exercising. I'm worried to do something. I don't want to worsen my symptoms. And so they kind of have, issues around that. And sometimes we need to put even acutely, some people want to do something, you have to put the reins on them a bit. Some other conditions like, maybe depression, there's a situation at anhedonia where they just can't get up, like we can't get them. So they have different issues. And really for concussion, the motivation is about trying to provide them, confidence that they're not going to, so-called worsen the neurometabolic cascade. They're not going to start, leaking anything at this issue. And the reality is you also need to kind of motivate them on the vastness of what exercise can help for sleep regulation, mood, and really try to have a behavior change engagement with those patients or users. And really what you want to do is start small. Like you just have small victories, have using very sound principles in goal setting, and just try to get small victories, because what we find is once they get over that first hump, there's a bit of a cascade. It's like, oh my gosh, it's okay, and you can build from that.
Okay. Another question is using those apps, is that something that we can be recommending to clients and patients to help guide exercise?
Yeah, so it is something that is available. I think our kind of Rhea platform is probably one of the first to market, so to speak, and I probably would expect more coming out in the future. But it is something that is, approved by Health Canada. It can be used, and obviously I would be biased in saying that I think it would be a good idea, but I do think it would be a good idea.
Yeah. Another question we have here along the lines of visual stimulus with a concussion and using apps. Is there a time period where it's too early, or it can be too early to start exposing clients and patients to these types of apps?
Yeah, that's actually a common question that people are typically concerned about, and it's a fair question. What I would suggest in those situations is people who have significant sensory issues or kind of can't handle screens, that may not be the best at that time. However, what I also encourage people is that you can chunk things. Like, you don't always have to look at the screen. You can watch it for a little bit, understand what to do, and then maybe come back later and not have to look at the screen and just do the exercises. So there are strategies to try to limit the amount of screen time. And I think we'll see more of those ways to kind of to address those situations, because it's a fair point. But I would say after a certain period of time, again, the persistent symptoms people, I have a little more of hard love there, is that I'm like, listen, you're a month post-injury. I know I'm not hurting your brain. I need to build up your tolerance. You just have to build your tolerance. Let's stress the system and see if we can build tolerance, because this whole wait and see approach, we can't keep this going on forever, because we know the disability and the problems that we just propagate if we don't try to stress the system.
Great point. Last question we have here is, the best exercise protocol to use is at the discretion of the clinic and their comfort, because there are multiple ways to determine exercise. Are there multiple ways to determine exercise threshold of a patient? Is it necessary to isolate the type of concussion prior to prescribing the types of exercise?
I'll just maybe answer the second one there, because I think they're related. Is it necessary to isolate the type of concussion prior to? I think when we think of engaging in aerobic exercise, I think there are many ways to go about doing that, and what's best for the user or the patient based on their abilities. However, the type of concussion is going to contribute to, say, do they need neck rehab under the umbrella of exercises? Do they need to do particular neck exercises? Do they need to do particular balance exercises, vision exercises? So I've used the word exercise largely for suggesting aerobic capacity or increasing from aerobic to maybe higher intensities. But exercise is more varied than that, and the type of concussion would have certain a la carte elements to it, whether it's vision issues, neck issues, balance issues. So that's what would contribute to the type. Is, I think, baseline aerobic activity can be done many different ways at the discretion of the practitioner. but the additional pieces, that targeted rehab, does require some knowledge of the type of difficulties they're having.
Awesome. Well, thank you so much for your time. That was our last question of the afternoon here. If you feel like you have more questions, feel free to reach out and we can try to get those answers for you as well. But I want to take the time right now to thank you, Dr. Hutchinson, for taking the time to speak to us about all your knowledge and education around this matter. And we really appreciate your time with answering all the questions that we had today as well. So thank you.
Yeah, thank you. Really appreciate it. And for any of those that are still on the webinar, feel free to reach out by email if you have any additional questions or interested in discussing more. Thank you.
Thank you.